Okay, everyone. So thank you for patiently waiting as we were getting prepared for 2 o'clock here, and the time is nigh, and I guess we shall get started. I am John Collins, and I'm with the Parkinsons Society, where my role is as manager of programs and events. And that means a number of things, and what it means relevant to today is that I take care of our pardon me, I wanted to say hello. I take care of some of our education programming, specifically a program that we call Get It On Time, and the focus of that is on Parkinson's disease generally, but really the role that medications play in the management of Parkinson's, and not just in the typical symptoms that we think of, but also in many other facets of their condition, and also just in their adjustment to life in long-term care and to hospital and other settings as well. So we started this program with the RNAO, and I mentioned that Heather Woodbeck is with us. She's a best practice coordinator, and we'll introduce herself in a moment. Heather Thompson and ourselves began a program in association with RNAO earlier this year and discussed Get It On Time, and it was really successful. I think the response was very good. Perhaps some of you attended that session as well, and coming out of it, it was identified that there was an appetite for better understanding on many different areas of Parkinson's disease, and particularly, again, in a care setting. So we decided to develop a further webinar series, and that's what you're attending here today. We're going to have a few other topics coming throughout the year, including a November session on pharmacology with a pharmacist that we do partner with. But today we're talking about responsive behavior. I'm happy to have Heather with us on the line, who's going to talk a little bit about best practices in a moment. And then we have Emily Prattle, who's a PRC in North Bay, and she's going to share her perspective on Parkinson's and responsive behaviors and best addressing them, but also understanding them in a long-term care setting. You'll see on the screen here, the way that we're going to run this today will be that ourselves we'll be talking to you, but unfortunately we haven't been able to integrate audio connectivity with all of our other sites. So you can just log in any questions via the chat box on the lower right-hand side of your screen, or if you have more detailed questions or one that should be answered after the fact, you can email them to myself and to Heather, and we'll address them afterwards. I know Emily's sharing her contact information after her presentation as well. So I believe that that's kind of all the perfunctory introduction. I'm going to turn it to Heather, who again will speak a little bit on RNAO's role. I'll talk a little bit about Parkinson's in general, and then we will leave the bulk of the presentation to Emily. So I thank you for joining us today. I hope that you do find it useful, and hopefully you'll come back for some more sessions throughout the fall. And with that, Heather.
Great, John. Thanks. Can you hear me okay?
You were coming through loud and clear on my end.
Perfect. Okay. So I'm really excited to be part of this and to share a little bit and to work together with John and with Emily. Responsive behaviors are a big thing in long-term care, and anything that we can do to help residents to prevent responsive behaviors is a good thing. So our objectives for today are pretty simple. We want to share best practices for resident-centered care for people with Parkinson's disease. We want to provide you with a very brief overview of Parkinson's disease symptoms and their management and why they're related to responsive behaviors, and then talk about ways to minimize responsive behaviors with people with Parkinson's and other neurological disorders. This is all based on the next slide. We have put the Residents' Bill of Rights, and this is directly from the Long-Term Care Act, where every resident, and I've just picked a couple of them that apply here to people with Parkinson's in all of our residents, but every resident has the right to be protected from abuse, to not be neglected, and to receive care and assistance towards independence based on a restorative care philosophy, and so that we can try to maximize their independence as much as possible. So these rights apply to residents with Parkinson's, and I think we need to keep that in mind, just so that so we all working in the same direction. The next slide talks about one of the best practices that applies very much in this scenario is the idea that we use resident or client-centered care. RNAO has an excellent guideline on client-centered care. And what the core processes in this guideline are to first identify residents' concerns and needs, to make decisions around them and provide caring and service based on those residents' needs, and then to evaluate how it goes. This best practice has some really good resources that go along with it in the RNAO Best Practice Toolkit that I'll give you the directions to get to later on. There's some excellent resources on communication that are applicable in this situation. But what this guideline reminds us is that we're trying to focus on resident-centered care. So this is very much in keeping with where the ministry's coming with the Resident Bill of Rights, and it's in keeping with best practices, and it's where we really want to go. The next little bit that I wanted to share with you is a few items from the Preventing and Managing Violence in the Workplace Best Practice Guideline. And I was surprised that this information is in the guidelines, and you might be surprised that it's popping up in a presentation on responsive behaviors. But it has some excellent recommendations there for team and individuals. And these are around that we need to acquire knowledge and accountabilities to prevent, identify, and respond to potential violence. And that we need to look at ourselves, our own practice, and look how our behavior as a caregiver could impact on other caregivers' behaviors, but also could impact on the behavior of the residents that we care for. And then the third one, little part that applies to us here, is practicing and collaborating together in a way that we want to foster respect and trust, and that's going to help to prevent violence in the workplace. And this is getting at the basis of some of these responsive behaviors. You'll see from what John and Emily are going to share that if we can offer residents with Parkinson's assistance on a timely basis and prevent their decline by getting their medications on time, that they're less likely to respond in a negative way. On the next slide, I've taken a couple of handouts that are from this Preventing and Managing Violence in the Workplace Best Practice. And it has in the appendices this checklist of risk factors for aggressive behavior. And so things to look at. There's client factors, and what doesn't show on this, there's organizational factors. So that we need to look both at what the client's doing, but we also need to look at ourselves and our organization. And you can get these online. They're in just have to download the guideline, and you can print that page easily. Finally, another useful tool is this, the one that's on our next slide, which is a point-of-care staff work practice assessment. And this one, I encourage you to have a look at it and look at your own practice and how you might be contributing to people becoming upset or sometimes inadvertently, but sometimes things like using really loud voices, coming too close to into a resident's space, not attending to their needs when they need them to, although I know there's lots of competitive competition for your time in long-term care, but we need to look at our own practice as well to make sure that we're minimizing the ways that people are responding to our behavior. The next slide I want to share with you, or my last slide, is this one on the Best Practice Long-Term Care Resource Toolkit. This has a couple different sections that it can apply in the situation we're looking at today. There's one, the one that's here that's up is the 3Ds, which is dementia, delirium, depression, and responsive behavior section. There's some excellent resources there that then are applicable for when you're working with people that have challenges around dementia or behaviors. And then client-centered care, of course, is the one I talked about earlier. And the website address is down in the upper or the lower corner there, so you can go and access. This tool is open to anybody. You just have to go fire up your computer, and if you put this into the browser, it'll come right up. And there's just a lot of useful things that you can find there. There's education things. There's self-learning tools. The one on delirium, dementia, and depression, I highly recommend. Anybody can use it, PSWs, RNs, RPNs. Even though this site is developed by the Registered Nurses Association, it is definitely not limited to nurses. We're trying to encourage the entire healthcare team to make use of these resources that we've gathered together. So with that, I'm going to turn it over to John, who's going to talk a little bit about the Canadian guidelines for Parkinson's disease.
That's great. Thank you, Heather. I will indeed talk a little bit about the Canadian guidelines on Parkinson's. My speaking itself will actually be very brief, as I've seen a portion of Emily's presentation, and I know that she's going to cover a lot of the relevant and important stuff on Parkinson's. But I do want to mention that recently, earlier this year, the Canadian Parkinson's Society and some of the leading medical experts in the Parkinson community worked together to develop clinical guidelines for the treatment of Parkinson's disease, and you'll see here that they were published in the Canadian Journal of Neurological Sciences at the end of last year. It's essentially just a review of existing guidelines, but it talks about a care relationship and how people with Parkinson's work into that, and it does address a lot of what we'll call the non-motor symptoms of Parkinson's, those things that go on under the surface that we don't always see or consider, and that's what we hear talking about today. So it is just an additional resource for your reference on the treatment of Parkinson's. Beyond that, I do want to acknowledge what I just said. We tend to think of Parkinson's as a movement disorder exclusively, and there are certainly physical symptoms of which you're probably familiar, and we will introduce you to a little bit in Emily's session, but there are these non-motor symptoms as well, and there are a few that I've highlighted here. Not everyone with Parkinson's experiences all of these things, and people will experience them differently, but I always take the time to highlight a few. Certainly a couple that are relevant are a sense of overall weakness and fatigue, and this one is really just something to keep in mind as we care and as we complete activities of daily living with people living with Parkinson's, and it's the number one symptom that they tell their neurologist has an impact on their quality of life. Emotional changes are common. Again, I'm sure that we'll be getting into this later on. Depression and apathy can occur fairly frequently, and anxiety happens quite a bit too, and it's relevant because stress makes some of the existing symptoms of Parkinson's worse. And in a moment I'll talk about, in particular, stress related to medication and its delivery in a setting where the individual has lost the ability to dose for themselves. Constipation, bladder urgency, dizziness, hypotension are also issues. And so are challenges with executive function. Really, with Parkinson's, we're talking about some difficulties with multitasking and prioritizing events. So if you come into the room as someone providing care and said, okay, we're with someone who's experiencing this symptom, that is, okay, we're going to get you up out of bed, go to the washroom, go eat, go have breakfast. Well, that's 4 asks in a fairly rapid succession, and we find that sometimes people have processing these things, so it's best just to make one ask and perform one action at a time. Lastly, cognitive problems are present. Again, dementia happens typically in advanced Parkinson's in a relatively small percentage, 30, 40, 50%. The numbers are still a little ambiguous. But one thing that happens in many people with Parkinson's that we don't often think about, or we often assume is perhaps a more complex cognitive issue, is something called bradyphrenia. One of the typical motor symptoms is bradykinesia, and that means slowness of moving, but this means slowness of thinking. And along with that symptom just comes challenges with finding the right word or processing thoughts, putting sentences in the order that people would like, and responding to you. And we just want to make sure in our care of people with Parkinson's that just because they're a little slow to respond doesn't necessarily mean that they're not understanding you, that they're being difficult or challenging, or that they can't be a part of their own care. And again, I know we'll see further details later. Another slide that I wanted to show you from my base presentations explains motor fluctuations. And I just think this is relevant today because it can be one of those symptoms or one of those realities of Parkinson's that sometimes shows up in other areas. So I will show you this. I'm going to, hopefully everyone can follow this video here. And the woman you see now is Judy. You can see here that Judy's able to write the date rather clearly. Her motor skills are functioning well. You can imagine how effective Judy might be at brushing her teeth, going to the washroom, doing whatever activities of daily living she'd like to do. In a moment, we're going to see Judy in an off state. And this here, as long as everyone's screen is keeping up with me, is 2 days later, same time of day, same woman, Mr. Drugs. Again, relating that to other activities of daily living, you can imagine the limitations that she might face. You can imagine the challenges in, again, dressing herself, brushing her teeth, things of that nature, and the level of care that she's going to require. Now, the reason that I showed this to you is to illustrate that, again, regardless of whether it's her medication or just a fluctuation in her symptoms, that is the same woman exhibiting very different abilities. And that, unfortunately, is a reality of Parkinson's for a number of reasons. And it can be common to assume that someone's exhibiting perhaps a behavior of some sort, and perhaps they are. I'm not trying to give anyone a free pass, but it's easy to assume that when you see someone up on their own moving well during lunch hour, and then in the evening they're insisting that they're stuck in their chair, they can't get up, they need a transfer help into bed. Again, sometimes those changes in ability are a reality of Parkinson's, and it's important for those of us who don't experience them to understand that. Really quickly, we have the conversation about Parkinson medication because by the time you meet them, if you are indeed staff working in hospital or long-term care setting, typically people have been living with Parkinson's for a number of years. Most people receive a diagnosis and live quite well for 10, 15, 20 years, often beyond, without any limitations that are sufficient enough to require them to have assistance in their daily lives. Diagnosis of Parkinson's, happens when someone has lost a significant amount of the brain cells that produce a chemical called dopamine. They only have about 20% of that left when they get a diagnosis. And then if you don't meet them for, say, 20 years, well, that person has very little naturally occurring dopamine left, and it's critical to the way that their body moves and also to the way that some of the non-motor symptoms respond. So by the time you meet them, they have very little left. They're therefore highly reliant on their medication, and it's just a point that I like to make whenever I am speaking. Beyond that, I said I'd come back to this, and then I'm going to turn things back over to Emily. We see a lot of cases in long-term care where people are accustomed to dosing medication at 10 a.m. regularly every day, and then they arrive in long-term care and it changes with rounds, or they're not administering their own dose, so they don't know when it's coming, and it gets to be 9:50 in the morning and they haven't seen anyone yet, and they're becoming anxious, and that starts to creep in a little bit, and then at 9:50, 9:55, because they're prioritizing that pill, it gets a little worse. And then if we don't see someone on rounds at 10 o'clock or till 10:15 or something of that nature, not only are they perhaps starting to have some challenges with their body because they're running low on a medication that's a very important fuel, but also they're seeing some challenges with stress, which makes symptoms of Parkinson's worse. It also makes behaviors likely more present. So again, it's self-serving because this is a conversation that I have all the time, but it is another way that we can reframe the idea perhaps of responsive behaviors in Parkinson's. With that, I'm going to leave it to our expert on the subject, and I'm going to ask Emily, who again works as a PRC in the out of North Bay Hospital, I believe. She's going to share some information further to that with you, and I thank her for joining us today.
Hi there. So I'm Emily Prattle, and I'm the Psychogeriatric Resource Consultant for Algoma. So I work for the North Bay Regional Health Center as part of an outreach program. So I work out of Sault Ste. Marie, but I cover a region from Hornpain out to Elliott Lake. And I work with BSO now, so Behavioral Supports Ontario. So what I do as a PRC is I work to increase capacity in different settings, so long-term care, hospital, community, and I provide education, so I do sessions like these in services related to responsive behaviors, dementia, and I also provide case-based consultation when we get referrals for BSO. So that's kind of an overview of what I do, and I know that BSO is a little different in each of the LINs, but in our LIN, we have an integrated response team with someone who's dedicated to supporting family members and then someone who does the assessments with our clients. So what I have planned for this session is, I know we already covered this, but give you a quick overview of Parkinson's disease and dementia, and then talking about responsive behaviors. And what we're really going to focus on is understanding triggers and unmet needs, and then how we can meet those needs and what we can do. So it's really about understanding the person, and there's no quick answer. If there was, we wouldn't be here today. So we're going to talk about how to problem solve. Oh, a little louder. Okay, I just see that someone's asking me, how's this? So I'll keep talking until I hear if you need me to talk louder. If not, I'll try and pick up the headset.
I think
All right.
you're coming through on my end anyhow, Emily.
Okay. And I'll try and talk a little closer to the mic now. So, okay, so what is Parkinson's disease? So we already talked a little bit about this. And though we know that we see the death of those dopamine-producing cells, we don't know why this happens or what the exact cause is. And again, the diagnosis, the age is so broad. So I mean, even though we say it's usually between ages 50 and 65, there's early onset Parkinson's, like we've seen with different celebrities like Michael J. Fox, for example. And then again, a broad range, 50 to 80%. We're not really sure how many people go on to develop Parkinson's disease dementia, but it does happen. So there's a number of symptoms, and then like we talked about already, there's those motor symptoms and then the non-motor symptoms. So the motor symptoms are probably the ones you're most familiar with, so the tremor, the muscle stiffness and rigidity in the arms, legs, and trunk, the slowed movement, the difficulties with balance. But then we also see a lot of non-motor symptoms, and these ones, again, not everyone will get each of these symptoms, so I'm going to talk about a large number of symptoms, but not necessarily that someone would have each of them. But it's important to recognize that these are symptoms of Parkinson's. So we see sleep disturbances in a number of ways, and then there's that dizziness, so that the low blood pressure. There's fatigue, the soft speech, constipation. We might see changes in mood, and depression and anxiety are big ones. Other cognitive changes, and then sometimes you see hallucinations and psychosis. So there's a wide range of symptoms that we might see that aren't necessarily as well known. Dementia though, so I'm going to be talking about Parkinson's disease dementia, but some of these responsive behaviors, the person might not necessarily have dementia, so they might not be diagnosed. They might just have a mild cognitive impairment, but it's important to recognize what we really mean when we're talking about dementia. And as I'm sure you all know, it's an umbrella term, so it describes a number of different conditions. So for example, Alzheimer's is probably the most well-known one. Then there's Pick's disease, and that's where there's damage to the frontal lobe, and it's related to frontotemporal lobe dementia. Vascular dementia happens when there's a lower level of oxygen to the brain, and it can occur suddenly. It could occur following a stroke or over time, or with a number of mini strokes. So there's a lot of variation there as well. And then we have Lewy Body dementia. So we see these structures, and we'll talk about Lewy bodies too, because you see them in Parkinson's disease as well. And there's structures in the nerve cells, and those are the Lewy bodies. And then that's when we start to see those changes in attention, the sleep-wake cycle. A lot of times we'll see hallucinations, and usually those hallucinations, you'll hear people talk about seeing small children or animals in the room. And then again, Parkinson's disease dementia is very closely related to Lewy body, and I won't go into too many details about how they differ, but it has a lot to do with the timing of diagnosis. And a lot of people, I mean, I'm sure as healthcare providers you know this, but a lot of times we'll hear family members saying when their loved one's diagnosed with a general dementia, they'll say, oh, well, it's a good thing it's not Alzheimer's, but of course it is a type of dementia. It's just in that umbrella term. So with Parkinson's disease dementia, the kinds of symptoms that we usually see would be attention deficits, difficulties with judgment, and executive functioning. So executive functioning has to do with planning. It could have to do with social appropriateness. Then we see that fluctuating cognition as well as memory impairments. And then the illusions, delusions, and hallucinations. And often these are paranoid, and sometimes when we're talking about hallucinations, it would be, like I said, those small children or the animals in the room. Illusions start out, you could see a spot on the wall and perceive it as being a bug, but it's from actual stimuli, but now you're misinterpreting it. Of course, mood disturbances like we talked about, and then the sleep disturbances, so sleep apnea. There's restless leg syndrome that can certainly interfere with sleep, and that doesn't necessarily occur only with dementia. So what happens with these sleep disturbances, you're not having that normal relaxation during the sleep. So with the RBD, someone might be acting out their dreams. They might shout, they might kick their partner, for example, and it's not intentional, but it's because of these sleep disruptions that it's happening. So why do we see behavioral changes in persons with dementia? So now we're getting into the why about responsive behaviors, and then I'll kind of describe what exactly we mean, and then all these triggers that we're talking about. So much of our behavior is directed at meeting our own needs. So when people do things, there's a reason for it, and usually it's because of an unmet need. So we think about what our normal needs might be, and everyone has these needs, whether they have dementia or not, right? So for example, the physiological needs might be the need for comfort, so preventing and managing pain symptoms, so the need to escape that pain, the need for health, safety, the need to feel safe and to be comfortable, and that can be, like I said, that could just be as simple as feeling comfortable. And then love and belonging, so the need for social contact, self-esteem, self-actualization, and this need for stimulation. So everyone has these needs, whether or not they have dementia. But get it on time. So this campaign has many implications. So we're not just talking now about getting the medications on time, but getting to that person's needs on time and helping them manage those responsive behaviors and identify those triggers. But of course, the medication piece is enormous in this. So it does apply in a lot of different ways. So we talk about behavior, and it's a form of communication. So when we see responsive behaviors, and you'll probably hear your local PRC talking in this way too, talking about responsive behaviors, and we really try and avoid the word aggression. And the reason why this is because it's for a number of reasons. So first of all, aggression doesn't really tell us what's happening. So we can say aggression, but it won't give us a good picture of what we're really describing. So does this mean that the person was cursing? Does it mean that they were physically angry with someone and maybe having responsive behaviors in a physical way? Were they aggressively trying to leave the building, for example? So we really want to, first of all, avoid using labels because we want to describe exactly what's happening, but also because it's not very person-centered. So we want to make sure that we're understanding that and respecting that maybe this is in response to an unmet need. And of course, there are times when maybe the intention is to harm someone, but we don't know that, so it's important not to label that until we know. And so knowing the person, this can help us to understand their behavioral expression. So what is their experience and what's their reality? So when they're acting in a certain way, what's going on that they need to do this, for example, okay? So I'll use a broad example of trying to leave the nursing home. So why do they feel like they need to do that? So do they think they're late for some special event? So then this could be, the unmet need would be anxiety, right? So, or they have that trigger, they're feeling anxious and they feel like they need to leave. So then how can we help support them and help accommodate that anxiety? And now when someone can't specifically tell you what's going on, so you and I, we might recognize our own needs. So you might recognize, I'm hungry. But if someone doesn't have the ability, the cognitive ability to communicate that, that's where we start to see problems, right? Because they need to communicate it in other ways and they can't explicitly say that they're hungry, and if you ask them, they might say that they're not hungry, so it's important to be mindful of that. I want you all to think about your own responsive behavior. So what kinds of triggers do you have that would maybe cause a responsive behavior in yourself? So for example, some people maybe would think of, and because we're not having the audio bridge, that I'll kind of give examples that I hear when I ask this question. So some people say, I get road rage. So maybe it's because those people, maybe they're running late and that causes them anxiety because they don't want to be late, for example. So other people's triggers, if you didn't sleep well at night, maybe the next day at work you're not going to be able to do what you normally would do because you never slept well. And this is a pretty relevant example to Parkinson's disease because of so many of the challenges with sleeping. But I just want you to think about when we talk about responsive behaviors, that anyone can have a responsive behavior. So Personhood, so this tool right here, now if you're interested in getting this tool, maybe I'll get John to send it out to everyone who agreed to participate. So this is developed by our local BSO team here in the Northeast Lynn. So you might have something similar that you use in your homes. Our form is quite lengthy, but it's very effective. I've seen shorter forms used in different settings, so it all depends on what the need is. But we use this tool to get to know the person, and it provides us a lot of insight into helping them and creating an individualized plan of care. So we know now what their preferred name is, for example, but so how to address them, and then we know significant dates and meanings, for example, or pets and those names. And pets can be a great source of comfort. So by knowing about the person, it's twofold. So now it helps us identify maybe what might be triggering them, because we know now that they really can't stand a lot of noise, and then now we know that maybe we should keep them in a quiet area, but maybe they wouldn't be able to communicate that to us. So it's important to get that information, but also when coming up with activities to help that person. And when we talk about Parkinson's, we're going to be talking about how to accommodate those activities to their capabilities, but knowing what kinds of things would work for them. So this Mr. Joe Jones, this is an example that I came up with, and it was based on an example that my team often use when we're showcasing the pieces of my personhood. So we actually filled out a hypothetical pieces of my personhood form to show how this form would be used in different settings. But I'm telling you a bit about Mr. Joe Jones' personhood because when we talk about the triggers that someone with Parkinson's might have, I want you to think how that might be relevant to this person because I really want to make that connection. And when I talk about the pieces framework, this speaks to the social part of that, so the S in pieces, and I'm going to go over that. I know not everyone has pieces training, but I'll explain all that. So Mr. Joe Jones, he's fluent in both Italian and English. He's proud of his medal from the military. He was known for being the life of the party in his social group, and he was also a very active volunteer in his community. He also had a dog named Charlie, and that was a great source of comfort for him. But Charlie, because Mr. Joe Jones is now in long-term care, he now lives with Joe's nephew in the community. Joe was also fairly active, so he used to play pickup hockey, and he ran about 10 kilometers on most days, so he liked to run. He worked as a car mechanic and made money from his paintings on the side, so he liked to paint too. Now I want you to think, I'm going to go over the symptoms and break it down into the pieces framework, how this might affect Joe Jones' quality of life and how we could accommodate him and maybe what kind of responsive behaviors we might see from him. So maybe now he's no longer to do the things that he enjoys, such as painting, right? And that can be really frustrating. And how would that impact, how would this condition impact his physical activity? So now he can't run 10 kilometers a day. So I just want you to kind of keep some of these examples in mind as we go through the pieces framework. So pieces is a best practices framework, and it comes with a lot of assessments. It's a 2-day course. I won't go into too many details on that, but if you're interested in taking it, you can contact your local PRC, and then we can talk about that. So physical. So this talks about triggers as well as unmet needs. So physical can refer to drugs, disease, disability, discomfort, as well as delirium. And then intellectual really refers to those 7 A's of dementia. And then we talk about, so amnesia, agnosia, apraxia, aphasia, apathy, anosognosia, altered perceptions. And then now we're adding an 8th A, which is attention deficits. There's also that emotional component. So, if someone's having trouble adjusting to their new setting or to a new big change in their life, changes in mood, maybe they're having delusions or personality disorders, capabilities. So this is a huge factor in Parkinson's disease is the ADLs and the IADLs. And then in environment, and we see this a lot in long-term care, right? So over and under stimulation, maybe the person's been moved. Maybe they're seeing a change in their usual routine, which can be really devastating for someone with Parkinson's who needs their medications at a certain time. The noise levels, the lighting, different colors, and then social. So we talked about that already. So what do we know about this person? Were they outgoing? What was their social network like? What's their life story? And what's their cultural heritage? And I'm telling you all this because Parkinson's disease doesn't exist in isolation, right? So what if someone has Parkinson's disease, a condition where you might experience that pain, and then they have arthritis on top of it, right? So these these things add up, right? So there's more than just Parkinson's. So I want you to think of what else could be acting along with Parkinson's when we see responsive behaviors. And we don't want to end with medication, so we want to know what their other needs are too. So maybe he needs exercise, and how can we accommodate him so that he can still get exercise even though we know he can't run 10K, right? So this is kind of a breakdown. So what I did with this slide was I took a list of common Parkinson's symptoms, and some of them you may not have heard of because some of them are not as common as some of the ones that you're more familiar with. But what I did was I split it up into the pieces framework because I wanted you to think about how these different factors might lead to unmet needs, but also might lead to triggers when we see responsive behaviors. So it could be any kind of responsive behavior. So I mean, there's a number of things that could qualify as a responsive behavior, but I'll just go through this and kind of let you know what I had in mind when I put this together. So physical. So someone they're drooling, right? Now they have a less sensitive taste and smell. They're having dysphagia, so trouble swallowing, nausea, constipation, pain, and weight changes. So think about this. So some of these, they interact, right? So someone maybe they're having trouble swallowing, but now they can't taste food as well as they used to. So that could lead to issues if they're not getting the same enjoyment out of food that they normally did, maybe because they're less willing to eat. But then think about the personhood. Maybe this is someone who's been a real foodie their whole life, and now that's something that they don't get that enjoyment out of it anymore. And that can lead to an emotional trigger because maybe now they're frustrated because of it. So intellectual, let's see. So hallucinations, cognitive impairments, apathy, excessive daytime sleepiness. A lot of these revolve around sleep. And then the impulse control disorders, losing your train of thought. So just thinking about that, how these kinds of things would interact. So the sleeping, that could cause physical symptoms because now they're feeling more tired because they didn't sleep well at night. And now it's affecting their capabilities because they aren't as able to do as many things because they just don't have that stamina. Under emotional, of course, there's depression, and that's a huge factor in Parkinson's. And then anxiety, plus the frustration from a lot of these symptoms. Again, these things interact and they affect each other. And this is just for Parkinson's. So now we think of the other comorbidities that this person might have, or maybe other triggers. So I didn't put anything under environmental, but that doesn't mean that their environment is always appropriate for them, right? So if it's someone who now they have that muffled speech, and maybe on top of it they have a hearing impairment, a loud environment might not be the best way to interact with them. So we want to be mindful of these things. And then, like I said, orthostatic hypotension, maybe there's sexual dysfunction. They have pain, challenges balancing and concentration. They're having those on and off periods and the freezing. Now, again, the capabilities is really the centerpiece because that's everything we can do, right? So that affects everything. So with someone who has Parkinson's, you want to get those medications on time because you want to enhance their capabilities as much as possible. And when you're helping that person, not doing more for them than they can do for themselves because we don't want to overcompensate either. And then environmental, so making sure that the environment is suitable for them. And then social, so again, like I said, so Mr. Joe Jones, I said he used to be the life of the party, but now what if he's having troubles communicating and following conversations and the slowed thought, so he's now slower to respond. Maybe this can impair his social life. I was watching video interviews with people who had Parkinson's, and for example, there was someone who was quite outgoing, and he was saying now that he was drooling, he felt embarrassed to go to social functions as much as he used to enjoy them. So it's important to think about how all these different things might impact that person's quality of life, and how they might act as triggers for that person, and how they might trigger responsive behaviors. Because you can imagine the anxiety of someone who, like we talked about earlier, doesn't think they're going to get their medications on time. I'm going to skim through some of the material because I know we're running short on time and I want to leave time for questions. This is just a quick slide to show how dopamine levels are lower in someone with Parkinson's than someone who's healthy, and why so many of the meds focus on raising those dopamine levels or mimicking dopamine, so as dopamine agonists, for example. So I'll just skip that slide. Here's an image of Lewy Body. So those are those abnormal aggregates of protein that we see in the nerve cell for someone who has Parkinson's disease or Lewy Body dementia. There's two kinds. I won't go into the detail about that, but this is just to show you that we can really actually see these changes after the person's passed away, so you wouldn't see this while they're living. But so what can we do and where can we begin? And this image is kind of, it's to show it's a lot to take in, and we need to know where to start, as well as getting it on time is such a big factor. That's the first line, right? So we want to make sure that we get their medications on time and meet their unmet needs in time, and being in tune with that person is a big first step to that. So with the PIECES framework, we have this 3-question template, and these are the 3 questions you ask when you see a responsive behavior. So for example, when I get a referral through BSO, these are the first things that we ask, right? So what's changed with this person? Is it a new change? And avoiding the assumption, so thinking atypical. So what could actually be going on? And that's why there's so many assessment tools, and not that you're diagnosing the person, but you're bringing these assessments to physicians so they have more clues when they're trying to figure out what could be going on with this person. And what are the risks of this responsive behavior? So why are we concerned? And it helps us identify where our priorities are, and what we need to do about them. And then thinking pieces, so going through that framework, not just about triggers, but what we can do to help meet those needs. And then talking about what's the action. So what kind of interventions do we need? How can we better interact with this person? And what information do we still need? So I advise you, if you're interested in this, either contact your local PRC again, or contact, if you have, an in-house PIECES staff member for assessments or suggestions on where to look for these answers. And I love this slide because by answering these questions, we're avoiding labels and we're avoiding making assumptions about the person, as well as normalizing the behavior, because it can be easy to normalize a behavior that's been going on for a while, but we don't want to do that. So for example, I've heard people say, this person's always calling out, but that doesn't mean that there's not some unmet need there that maybe has been an unmet need for some time. So we want to make sure that we look at everything and look at the whole picture. We need to really dig deeper. So, and why is this person doing what they're doing? What are they trying to tell us? So are they in pain? Are they hungry? Are they thirsty? Are they worried they're not going to get their medications on time, right? So that can be a huge trigger. So how can we accommodate this person as well as their capabilities at the same time? And again, avoiding doing more than we need to. So I know I already used this example where we say, maybe someone has the general pain from having Parkinson's, but then they also have arthritis. But now if we imagine that it's Joe Jones, our former marathoner, how might this be frustrating? I mean, now he has this pain and he really can't do it. So maybe in this case involving the OT or the PT to see what we can do to help this person out. Avoiding assumptions and labels. So we really want to be objective, so not using that this person was aggressive with me, for example, because we want to say what really happened and describe the whole situation, because that's how we problem solve. So for example, cogwheel rigidity and lead pipe rigidity are common in Parkinson's. So the cogwheel, that's what this image is showing, and those are those jerky movements that you see. And lead pipe rigidity, where the resistance is more sustained, can be labeled inaccurately, and it's no one's fault, right? But it can happen where someone might perceive that as being resistant to care, but that might not be the case. So we want to make sure that we're patient with this person and we take our time with them, and that we're not labeling it till we know what's really going on. And then if we find out that this person has these on and off periods, then planning around when we know that they tend to be on. And then with those impulse control disorders, when someone's maybe, for example, cursing, or maybe they're more impulsive with their behavior, it can seem very intentional, but it's important to remember that it's not. It's very similar to when you're consuming alcohol, and maybe something that you said seemed like a good idea at the time and you've really upset someone, but at the time you didn't have that filter. So that's what happens a lot with these impulse control disorders. So the part of the brain that would normally tell you, oh, you might not want to do that, that's a bad idea, it doesn't have that control anymore. So you think about doing something and you do it. So again, it's important not to label this person. So maybe when it's a sexually expressive behavior, we avoid labeling them in that way, because we want to be really careful that we understand what's really going on here. And then instead, because you're not going to reason with that person, you can't punish them, maybe finding out what's really going on and seeing how we can accommodate them. This diagram shows a typical day with Parkinson's disease. So it talks about those on and off periods. So it shows that there really are those on and off periods, and that those medications, the timing's really important, right? So we want to make sure that we're managing the medications to give more control to the resident, and working in their on periods, like I said. And if you need to, you can use behavior tracking tools to find out when those on periods are if you're not quite sure, or if you find they fluctuate. So we need to be really extra accommodating so we can maximize that C part of the pieces framework and make their day easier, but not only their day, your day as well, because now that they're on, they can do more, and care tasks won't take as much time. And on periods would also be a good time for activity planning with that person. So if you want to do activities with them, that's a really good time. And mindful communication. So communication with someone with Parkinson's, there's tons of considerations. And this is really speaking to the I, the C, and the E, and the S of pieces. So again, these things all overlap. But choosing the best time to communicate. So if this person has on and off periods, then maybe you would want to pick an on period when you're communicating with them. And keeping your communication simple. So like John said, not telling the person to do 4 different things all at once, but maybe step by step and really breaking it down so they can really absorb what you've said. Reducing distractions, so especially if someone has an additional hearing impairment, but also that they're having that muffled speech, reducing distractions can really help communication. And then speaking slowly, clearly, carefully, and being mindful of body language. And body language is enormous. I think it's easy to overlook how important this is because, for example, think about it. If you have the TV on and you mute it, without hearing the dialogue, you can't hear anything, but you still can tell by the actor's body language what message they're conveying. So if they're having a fun conversation or if someone's upset. So keeping that in mind, that body language is really important, and you need to be mindful of it and not show that you're frustrated, even if your words are maybe masking that. So being really patient and with your body language, conveying that as well. And if you need to, you can use visuals, and I know that you can get communication boards if that is helpful too. And then if the person needs hearing or vision aids, making sure that they have those in, because that's super important too, and it will really help that person. And then focusing on the person, not on the task. And how can we do this? So again, this is that social piece of pieces. And we can do this by getting to know this person. So knowing their likes, their dislikes, their hobbies, their interests. And this will give you something to talk about while you provide care or while you're just making conversation with them. But it also helps build a relationship with that person and build trust. And knowing that symptoms vary. So like John said, just because someone's able to walk around one day and then the next day they seem like they need a lot of help, they could very well be that because the symptoms do fluctuate day to day and throughout the day. And helping the person to relax. So it can be really stressful for someone if they see that, for example, they're slow and someone's frustrated with them because they're not moving maybe as fast as that person would like. And that anxiety can actually make their symptoms worse. So we really want to make stress as much as possible. And then focusing on one task at a time. So we already talked about that. And if you need to, review their meds, so get the physician or the pharmacist in and see how we can support them. And recognizing that you may not be able to read that person's facial expressions. So you're going to need to get to know the person behind the mask. So the person with Parkinson's can seem very straight-faced, but that doesn't mean they're not happy, but it's just more difficult for them to express themselves because of their muscles. And then exercise is another big thing. So making sure that person is getting exercise, and especially if it's someone like Mr. Joe, where he's done it his whole life and it's important to him. And that can help make him happy, right? So we want to make sure that this person is having a really holistic approach to care. And by meeting these needs, we're minimizing responsive behaviors, right? So we know we might not get those responsive behaviors to go away entirely, but we can accommodate this person and help reduce those as much as possible. And then finally, involving the whole team, right? So making sure that team members are consistent. So everyone needs to be on board. One person, it's great if one person's doing this amazing approach, but what we really need is that the whole team knows about it and that everyone's on board and that they've had a chance to express their concerns so we can accommodate that. if possible, speech language early on, and then getting the whole care team involved. So we really do need a team approach. So now I just went back to this slide kind of as a wrap-up. So thinking of how these things kind of mix together, and hopefully, I think someone asked if the slides will be sent out, so I think they will, but thinking of all these symptoms and how they might not be as obvious, and you might not have formally recognized them as Parkinson's symptoms, but knowing that these can impact this person greatly, and it goes beyond the Parkinson's, so it might interact with other things going on in their lives, and then they're becoming more frustrated. So being as patient as we can with this person and really giving them time and taking the time to understand them. So thank you for your time. If you have any questions, now's the time to ask. So if you want, you can always contact me. So I gave my email and my phone number. But that's about it. So these are pretty general suggestions, but once you combine it with what you know about that person, it should be helpful for coming up with a way to accommodate them and hopefully help address those responsive behaviors that we tend to see in long-term care. So thank you, everyone.
All right, well, thank you, Emily. I'm going to just bring this back, and there were two questions that came in during the session, one of which I think we'll take offline. I want to thank you for sharing that. I know for everyone who is attending, we covered a lot of good information, but we covered it pretty quickly. So in response to the question that came in and to what Emily just said, we are going to make this session available by archive, hopefully very quickly. When we leave this session, it's been recorded. I have a little work to do with it, and then I will share it with everyone. So I'll be following up with a message probably on Friday of this week with the archive link to the video presentation, as well as the link to the survey where you can share some feedback with us. Again, thanks, Emily, for sharing that. I think beyond the discussion of behaviors and their characterization, I think you've done a great job of sharing with us things that we often, I guess, take at their face value without understanding the underlying reason. You mentioned impulse control issues, and of course those can become apparent in Parkinson's, but not always because of the condition itself. Perhaps there's an offending medication that's causing some issues, things of that nature. So I thought that was very helpful, as was just in general the discussion of our goal and my goal whenever I speak is not just to help raise quality of life for people with Parkinson's, but also to make the job of carers easier. So I know that you addressed that, and I hope that this session has achieved that goal as well. Quickly, two questions did come. The first one was regarding a PAT test for Parkinson's, and I'll say, unless, Emily, you can provide some characterization as to what that is, it's probably better left offline. I think we may be discussing a PET scan or some other test. Are you familiar?
No, I'm not. I'm wondering if it's what it stands for, though.
So Mansoor, I'm actually going to take your question and forward it to Robert, who, if I'm remembering you correctly, who you're familiar with, and hopefully he can follow up with you on that from there. And I see you typing. The other question that came in, I guess, was more for me, and it was a medication timing question, and the question is, how do we help these residents get medication at a time when they need them, which tends to be different for everyone, particularly with Parkinson's, when they're exhibiting lethargy or, what was the specific question, or they're unable to swallow or they're having other issues. And one of the things that you mentioned is indeed there is a higher choking risk in people with advanced Parkinson's in settings where most of you work. So that's relevant. Very generally speaking, I will say that Parkinson medications can be crushed. I'm certainly not trying to provide medical advice here, nor on an individual basis, and I hope that that's clear. This is being recorded, so I think I've characterized that pretty well. But we want to make sure that, they can be crushed. Swallowing issues are present. Most of the drugs can be crushed. It's just the controlled release versions that we're worried about. So having that conversation with hopefully their primary care neurologist, but certainly a doctor who's responsible for the patients in your home, finding, if it's not the med that they're currently on, another one that can be addressed or delivered more effectively, more efficiently, because ensuring that people receive it helps them meet their activity of daily living goals, but it also helps prevent further challenges of swallowing. Same sort of thing goes with being tired, with lethargy. I understand that is very relevant in Parkinson's disease. My roundabout answer is going to be achieving proper medication timing actually helps prevent the onset of that fatigue. Again, we were talking about clients who have an advanced condition, who have progressed rather rapidly, so I'm not trying to present the drug as a miracle fix-all, but I am saying that if we can find ways to address good medication timing and also achieve other activities of daily living when that patient, when that resident is well functioning, you should find that those times are actually reduced. The other thing is about structuring your day and perhaps even the medication schedule around times when it's optimal for them. That's a much bigger conversation, though, again, to have with members of the healthcare team. I hope that was a sufficient answer to your question, Jennifer. If not, you've got Emily's address, and I did provide mine earlier, and we can perhaps take this conversation offline. Failing that, I see no further questions coming in, so I want to say thank you to everyone for attending. Again, big thank you to Emily for sharing her expertise, and a final thank you to Heather, who has brought the RNAO to the table and allowed me and the Parkinson's Society to reach an audience that we don't often have a chance to speak to. So I thank her for that. I thank you all for your time, and I'll leave Heather with parting words if she has any. Thank you again.
Well, thank you, John. I think this was a really good overview. I certainly learned a lot, and Emily, I really appreciate you applying the PIECES framework to residents with Parkinson's, because I've learned the PIECES framework, but seeing how it can work in action was really illuminating for me, so thank you for that.
Oh, thank you. Yeah, and with that PIECES framework, one thing I think that is interesting is how something can go under so many different domains, right? So like the pain can affect the emotional.
Yes.
So yeah, well, thank you.
Okay.
Okay.
Well, have a good day, everyone.
I guess that leaves it at that. Again, thank you for your time. We'll follow up with the archive. We'll follow up with a survey and with an invitation to our next session in November. So thanks, everyone. Take care.
Bye-bye.